Welcome to Glow for Hope, sparking conversation on mental health, where we break the silence, build community, and ignite hope. We're here to talk about what really matters: mental health, wellness, and the conversations that help us all feel seen and supported. Every episode will bring real stories, expert insights, and practical tools to help you navigate mental wellness and suicide prevention. Because together, we can change the conversation. Let's get started. Welcome to another episode of Glow for Hope, Spark Conversation on Mental Health. I'm your host, Kelly Pelker. Today we're diving into a topic that so many people think they understand, but very few of us were ever truly taught, and that's the difference between a mental illness and a mental disorder. And to help us break this down, I'm so excited to welcome our guest, Dr. Arcella Daniels. Dr. Daniels is a licensed psychologist, counselor, and clinical supervisor with over 30 years of experience. She's worked in schools, outpatient clinics, private practice, and more. And she's deeply passionate about training the next generation of master therapists through her company, Peak Development Group, which is actually where I met her from. So whether you've been diagnosed or feeling off or not sure why, or you're just trying to better support the people in your life, today's episode is for you. So welcome. I say Dr. Daniels, but I'm so used to calling you Arcella. So.
Okay, yeah, that's fine. Thank you for having me. It's wonderful to work with you again, and I'm very excited to be here. So thank you for thinking of me and allow me to go with this next journey for you. So I appreciate being here.
Absolutely, I'm super glad we were reconnected here. I always enjoyed our conversations. So for the sake of this one. Let's just start off with what is the difference between a mental illness and a mental disorder, and are they actually different?
Yeah, that's interesting because most times people use them interchangeably. And so there are times, I guess it's like a continuum we kind of look at, mental health providers look at it as a continuum. So there are some things that you engage in or behaviors that you engage in that may not meet what we would call the diagnostic criteria for an actual disorder. So for example, if you smoke, you could get a tobacco use disorder, but if you only do it a little bit or something like that, then you may not. Or alcohol, for example, probably be most common because a lot of people drink. But if you're not drinking in excess, then we wouldn't give you a disorder. So we kind of look at it as a continuum, but anything that you engage in that's causing you problems with functioning socially, occupationally, or in any other areas, we start to look at those as disorders, especially if you're not able to stop them.
Okay.
So,
Okay.
you know.
And so I think probably the most common ones that people relate to is the whole anxiety and depression. But there's different forms of and levels of disorders even within those two terms, right?
Right. And that's what's interesting. So the cool part about mental health now, that being in it all these years, that I'm excited about, is that people are now starting to talk about it more, and they're starting to actually go seek help. Whereas, in the past, in years past, when I first started in the 90s or so, a lot of people thought it was a stigma to go see someone and things like that. And so now, with, I think, social media, also just with us talking more, we are able to go and get help, which is pretty cool. And so oftentimes you will see that depression and anxiety are the most common diagnoses that people talk about. And generally over the years, that is mostly what you see when people come. But what's interesting is, and I think I was talking to you about this beforehand, is that I could diagnose anybody with anything at some point in time, right? Because, for example, bereavement is a mental health diagnosis. Insomnia is a mental health diagnosis, which a lot of people will likely experience if you live, right? And
Right.
One of the other most common diagnoses that we generally give is what we call an adjustment disorder. And an adjustment disorder is basically just a response to a stressor that a person has. And if you have an emotional or behavioral response to the stressor and it lasts like 3 months or so, then we can consider that an adjustment disorder. And it can come with anxiety and depression. So we have these qualifiers that we can add to the adjustment disorders, but every single person living pretty much will experience an adjustment disorder multiple times in their lives. And what's also interesting about adjustment disorders is that they fall. We have a book called the DSM, the Diagnostic Statistical Manual, where we,
Right.
actually have our diagnoses. Well, adjustment disorders fall under trauma in that book. And so that was interesting to me, which I just figured that out like not too long ago, a couple of years ago. It just hit me. And you think about it. So as you live, you might experience little
Mhm.
traumas throughout your life. So they may not be to the extent of a PTSD, for example, or a post-traumatic stress disorder, but those little life traumas. And guess what some of those adjustment disorders are? Because I bet you've experienced them, because I've experienced them, and probably people listening have experienced them. But guess what some of them could be?
I'm sure I am. I have because I'm one of those that's like, I don't consider, I could never identify a trauma, but it probably really is. And it just, it's just so small. You compare it to everyone else and they've got these massive traumas that have happened in their life and stuff. But there's a
Yeah,
lot of things that are really traumatic experiences that we don't really think are that way.
yeah,
So what,
and
so give me this, what is it?
some of them are leaving school, moving,
Mhm.
becoming a parent, changing jobs, or marital stress, or I'm trying to think of some common, just common things that we have. Let me see if I see any other. Yeah,
Moving.
just moving. Yes, just any of those things, and pretty much all of us will experience them at some point in time. Yeah, and the funny part, even with anxiety, we actually have an anxiety scale that found that many things that we do that we consider good, that we enjoy, or that we're excited about, can still cause anxiety. Getting married, like you said, moving, even if it's to a new house, starting a new job, starting a new career, those types of things that we think are exciting can also be anxiety provoking. And that also can cause us to have adjustment disorders. So again, as you start to think about it, it's this continuum. Because once you start the job, then are you still anxious? Probably not. So that's why adjustment disorders, after about 6 months, generally, if the issue is resolved or the consequences have occurred, then usually you kind of go back to typical functioning until the next stressor occurs. And
So then
so,
wouldn't that mean that like everybody on Earth, unless they're living in a bubble or under a rock, I mean, like you said, at some point in time they experience one, they may not classify it as that, but then does it, like when to seek therapy and stuff, or that you need medication or anything, when does it become that next level that requires something more? Like it's more, I don't want to use the word chronic, but it's, I don't know, is it a culmination of all of it? You go from one disorder to another, or sometimes, like bipolar, or what is it, borderline personality disorder? How do you define or categorize or distinguish between all of them that exist, or you know what I'm saying?
mhm. Yeah, so what happens is, so diagnoses are technically a list of behaviors and that have been clustered together to, and we call it something, right? Now, when you start to think about those extremes, which is kind of sometimes us mental health providers kind of be like, like when people call everybody bipolar, or they call everybody, they have schizophrenia, things like that. That those diagnoses are really rare, because we're starting to now get into personality disorders and things like that, or even the narcissism that people talk about a lot. Those don't occur as frequently as we would think in society. So sometimes people are just selfish. Are they narcissistic? They're probably just selfish. You see what I mean? So those types of diagnoses generally don't occur as often. But like you said, that depression, anxiety, the adjustment disorders, and things like that, they become problematic when they are impacting for long periods of time your social, occupational, and other life functioning. So when you're having trouble at work, when you're having trouble with your family, and it's over long periods of time. Adjustment disorders, like I told you, generally are 3 to 6 months, but they do have chronic adjustment disorders that could last over 6 months. And then, like you said, it could be also, we have what we call comorbidity. So you could have an adjustment disorder with depression and anxiety, or you could have anxiety and insomnia. You could have depression and anxiety. So sometimes they overlap, but the issue is that many of the same symptoms occur with those diagnoses. So that's why sometimes you don't get like multiple diagnoses and things like that. But it really becomes an issue when you feel like you can't function.
Okay.
And you're having trouble functioning.
Okay. So does it make sense for our listeners and getting people to kind of understand, like, okay, what is considered, what are the top 5 disorders and I don't know, when we break down kind of like, what is bipolar? What's it mean? What is, post-traumatic stress disorder? What does that mean? I'm drawing a blank on some of the other ones.
Yeah. And again, those diagnoses, and you probably can have a whole nother show about those, because those don't usually occur as often. So I would say, if you think about the top 5, I would say the adjustment disorders, as I told you, because pretty much anyone we could diagnose with adjustment disorder. Insomnia is one. And of course, you may have colleagues that listen to this and disagree with me. I'm just kind of getting them off your head. I don't know if the order or anything. Depression is another one. Anxiety is another one. And just other common one that you might hear is attention deficit, hyperactivity disorder, or ADHD could be another one that we often see. I'm trying to think. In my practice, when I was practicing, I worked with everyday people with everyday problems. Now, if you have colleagues I had colleagues who worked in inpatient facilities and things like that, that's where you'll probably see more of the other diagnoses, like the bipolar disorder, schizophrenia, things like that. So, if you talk to those colleagues, they could tell you differently from that perspective. But from the general population, you will generally see, like I told you, the depression, anxiety, adjustment disorders, insomnia, ADHD, bereavement. And then we used to have these things called V codes where, but now you can add them on, but they're kind of just like other life events, like legal issues or family problems with your spouse, problems with your children. So those also can be a part of those diagnoses. So the majority of our diagnoses that are common are just things that typical people might experience at some point in their life.
So I would refer to that as more things that impact your mental health versus a disorder.
Right. And that's the thing. And that's the other myth about mental health, is that people think that I have to just be like rock bottom, just falling out kind of thing, not really getting it to come to get help. But actually, what I found over the years is that people think about some of the things that they're having, especially if if you have multiple stresses occurring at once. Right. So if you're moving, and then you have problems with your spouse, and then, you have money issues as a result. Those are multiple stressors that might all be related, but they still might make you feel different based on, because they're occurring in different settings and things like that. And so many people try to work through their mental health concerns with their family and their spouse and things like that. But what if, or their significant others and friends and things like that, but what if they are part of the stressor? Then you don't have anybody to talk to. So that's why I always try to encourage people to come when those stressors start to come, especially multiple stressors. Even though we know eventually they can resolve, why not come and speak to somebody about them before they get out of hand or before you get overwhelmed?
Because I don't need to tell some stranger all my problems.
Yeah,
all the time, and I'm not even in your field.
Which is really interesting, because the cool part about telling a stranger your problems is twofold. One is that we listen to you for 60 minutes, right? So how many times in your life do you actually have somebody sit and really listen to what you're saying? To think of, for an extended period of time. I don't care how much they love you, but many of your family and friends are not going to listen to you that long without interjecting or without giving their opinion and things like
Guilty.
that. And that's the other second part of it, is that we don't have that background so that we can say, well, yeah, I hear you talking about your money, but you went and bought a purse the other day. And you see what I mean? We don't have those things, at least initially. Now, later on, of course, we have things that we'll bring back and talk to you about from based on what you said, but we don't really have that background. And so it's kind of like talking to a clean slate kind of thing.
Mm.
And sometimes you are like the people that you're around. So it also is good to get a different perspective that you may not have had by talking to people who are around you or even talking to yourself. Right. So
Do that a lot. I'm pretty smart.
and I always tell people, if you could do it yourself, you wouldn't, it would have been
Right.
done. Like you could stop yourself from doing certain things, you would do it. So if you figure out, and so that I guess that could answer your question too. If you figure out that you keep doing something and you can't stop it, or it's not, you're like, I want to be different. I want to do this differently. I want to think differently. I want to behave differently. And you keep saying, okay, I'm gonna do it. Then you start on Monday, and then by Tuesday afternoon it's over. Then, and it's impacting your life, then you need to get some help. And it doesn't have to be that, I think people think, oh, I gotta be homeless, or I gotta be, people don't like me, or I gotta be, just so bad that before I get help. It doesn't have to be that way.
It's
And
just somebody to talk to, and with no judgment.
exactly,
It's no
exactly.
judgment. Even if you do talk to yourself, there's judgment in that.
Yes, exactly. Probably the most judgment. I remember seeing some
Right.
study talked about how many negative thoughts we say to ourselves over and over. So yeah, definitely,
Yeah,
definitely.
there's a number in like the 6 or 5 digits of how many negative thoughts we have a day. And
Hmm.
it's
Hmm.
pretty alarming. I don't remember what the number is, but when I heard it, I'm
Yeah,
like,
it's
holy
big. It
cow.
was huge. It was
Holy
huge.
cow. Okay,
Hmm.
so you keep using the word disorder in all of that. What then is mental illness?
Like I said, I don't know if we distinguish the two because um because generally what I say is mental health. We say mental health concerns. We start looking at language, so it's more mental health concerns like that illness, and even with the diagnoses. Now you'll find that different practitioners are different. Once I give someone a diagnosis, I'm not really talking to them about the diagnosis in my treatment. I'm not saying, since you're depressed, you got to do those. Since you have depression, you got. I don't usually do that. Now I'm looking at what's going on, and then let's figure out what behaviors are associated with it, what things you say you want to change, what do you need help with, and then we kind of go from there. So we're trying to get away, because the only problem with talking about like it from a mental illness or even a diagnosis disorder perspective for some people is that they hold on to that and think that that's them. Now, there are
Hmm.
some diagnoses that we don't think can go away. It can only be like, if we think about a schizophrenia diagnosis or a autism diagnosis, for example, we think about those things that can be treated, but maybe not necessarily, totally
Yeah,
gone away.
managed.
Yeah, managed. Yeah. And so, when you even thinking about those diagnoses, it's still more of okay, you are a person with this diagnosis as opposed to being the diagnosis. And
Gotcha.
so if you look at it from that perspective, then you're able to change and you're able to grow and you're able to, and so, yeah. Um,
All right. So are there other myths related to mental health that you feel are
yeah,
important to share?
one of the big ones is that they think that all therapists are the same. So I've had people that come like how you said what you heard about, I don't want to talk to a stranger. One of my other ones that I hear all the time is I went to therapy once and I didn't like the therapist. And so I never went back.
Hmm.
And it's like, therapists are just like, or mental health providers are just like other types of provider or service providers. You go to a lawyer, you don't like them, you go to another lawyer. Medical doctor, you go to another medical doctor. I always tell people like, if you like hamburgers and you go to a restaurant and the hamburger's bad, you don't stop eating hamburgers. You just don't ever
Right.
go back. And
You have
so
to
that's
find
the
the right one for you.
Yeah, and it's the same. So for some reason, people like I try, and I think some of that comes from, in their defense, I think some of it is coming from, like you said, what it takes to actually go talk to a stranger or go talk to somebody, and then when you do, you're like, oh my gosh, the experience wasn't that great, and I don't know what people are expecting sometimes, because I also have heard sometimes people say, oh, they didn't do much, they just listened to me and nodded, and it's like, well, our job is not necessarily to tell you what to do. I always tell people, I don't tell you what to do, I help you do what you say you want to, which is
Okay.
different. You
So
know,
that, but you're a psychologist also, right?
yes, I'm a counselor and a psychologist. Yeah.
So even from the standpoint of being able to administer medications and stuff like that, there's you have to go to a psychiatrist versus a psychologist versus a therapist, and
Mhm.
how does it make a difference which one that you go to, or who do you go to for what?
Well, see now,
We could cover in another episode to a degree, but I would love to get your take on it as well.
yeah, and this is the thing, and going along with that myth of, we're all the same, one of the things that I would suggest that people do is talk to the provider. Now there are times when people would call the office and they'd ask to speak to me, and I would talk to them briefly. Now, I'm not going to talk to you for a whole hour, right? Because, you'd have to sign stuff and do all that. But if you just want to say, hey, how do you look at mental health? How do you look at this? And how do you do this? How do you practice? That's something to think about, because you might say, okay, well, no, that's not what I was looking for. That's what I was looking for. So with the psychiatrists, generally, of course, they are the ones who administer the medication and work in conjunction with psychologists, counselors, and things like that, social workers. But the issue is it depends, because some psychiatrists don't do therapy per se. They do medication management. Some. So that's what I'm saying. I'm not, for all my colleagues out there, I'm not saying everybody's the same, but just in general. So you'd have to ask them, do you provide therapy or medication management or both? And see about that. So sometimes in my career, I generally did the therapy and then referred them to the psychiatrist, and then we kind of collaborated on how the medication was impacting their treatment.
Mhm.
So it just depends on that. There are actually some psychologists who administer medication, but they had to go back to school and things like that. But it's very few of them. So.
And are there different there's different types of therapies or techniques or whatever, like there's the cognitive behavioral therapy, and um,
Mhm.
I don't that's really mainly the one that I know the most about. I'm sure there are others, but are the those are just techniques that you use to change those behaviors, right?
That's it. Yeah. So what happens is we call them theoretical orientations. And so when they're in school, so I'm a professor now, so I teach new therapists. And so what I'm teaching them is how, basically a theoretical orientation is how we see how people got the way they were, and then how do they change. So I'm a behaviorist, for example. I'm trained as a behaviorist. So in my thought process and how I look at someone who comes to me, I'm going to think that the way they got the way they were because something happened in the environment. Right. So I'm going to ask them, hey, tell me about your childhood. Tell me about this. Tell me about what's going on in the different areas so that I can see what's environmentally going on. And then I'm going to figure out, okay, to change behavior, the best way to change behavior from a behaviorist perspective is positive reinforcement. So then I'm going to talk about that. I'm going to talk about consequences and punishment and things like that. That's that theory. Then one of the most popular ones is what you mentioned, is cognitive behavioral theory or therapy. And that is Aaron Beck started that, but it's variations of that even. And so what happens is you're looking at how people think and how they feel, and then you're putting those together. And depending on what type of cognitive behavior therapy you're doing, it varies somewhat. But yeah, that is how we will conceptualize what's happening to you. I'm trying to give you a quick example. Like, as a behaviorist, if somebody comes, I worked with couples toward the end of my career. I did couple work. And if say for instance, a spouse said, oh, my husband doesn't take out the trash. And then, even though that doesn't sound big, but that's just one of those little things that as you keep adding it up, right, it's
Mm.
imploding in the relationship. And so then I said, well, what happens before you take out the trash? And then it's like, I don't say anything. Then what happens after? I nag or I yell or, things like that. So then I'll say, okay, what are you doing when he does everything else that you asked him to do? Well, I don't do anything. Okay, well, the best way to change behavior is reinforcement. So when he does take out the trash, so you tell me he never takes out the trash, because that's that extreme thinking, right? No, somebody
Right.
never does something, they always do something. Those are too extreme. So we stop those types of things. And then I'll say, well, when he does take it out, what do you do? I don't say anything because he's supposed to. Well, but reinforcement changes behavior. So, oh, thank you, babe, for taking the trash out. I appreciate you so much for that. Or when you see him doing something else, thank you so much. You see what I mean? So I'm looking at it from some type of perspective, and that's what we're doing. So it's usually not us talking from ourselves. We are talking about, why is he not taking out the trash? What's the problem? What's happening? You see what I mean? So we use those theories to conceptualize. There are other ones, psychodynamic, humanistic, but most common you'll probably see is cognitive behavioral in some form. We have this a thing called ACT, acceptance commitment therapy, solution focus. So you'll see quite a few of them. And there's a website, I don't know if you talked about this on your podcast yet, but there's a website called Psychology Today.
Mm-hmm.
And you talked about already. Okay.
We haven't talked about it, but I'm familiar with it.
Oh, okay. Yeah. So you can, anywhere in the country, you can put in your zip code, and then you'll see different mental health providers in your area. And they usually have pictures up there, and then they usually have their specialty areas and usually what theory they use and who they assist and things like that. So I often send people there so that they could see if they could, find someone and start to kind of go through them and look at the profiles and things like that and say, okay, this person might fit with me. And then if they don't, then just find somebody else, because we're hoping that my big hope would be that people would kind of go and get a mental health tune-up every year, look at their life and say, is there anything I could do differently? Is there anything? Or as soon as something comes up that's a stressor, they figure out a way to go talk to someone. Some of my best clients over the years I had some clients that would come for years, and they didn't come often. Like if they had a new stressor, they'd call me. Might be a year I hadn't talked to them, and then, hey, I got a new stressor, or it might be 6 months. I'm getting married, I'm moving, I'm doing this. And so that's the type of relationship you could have with the therapist, so that you can kind of run things by them too, to assist you in those times where you need extra assistance.
So just to take this to another extreme, because so many, and I guess this is more from my understanding, would be more from the, like a suicide attempt, or if someone's feeling suicidal or whatever, that, you're going to put into a inpatient treatment or something of that nature. And what can you speak to any of that, or what, disorders or conditions or things would be going on where someone is better suited to have inpatient treatment versus, outpatient onto therapy and the psychiatrist medication management stuff?
Yeah, anytime where you feel like a person is not themselves. So when you think about diagnoses like schizophrenia, for example, if they're hearing voices or they're seeing things that are not there, or the disorders that have manic pieces where they're just like shopping a lot or doing a lot of things that are taking them outside of who they typically are in terms of their functioning, then that's what, or of course, if they're threatening to harm themselves or someone else, that's when we generally recommend inpatient care. And it depends on how you get that care, depends on kind of where you live and things like that. But there are inpatient hospitals. The only problem is with the inpatient hospitals, which is why we talk about making sure if you can get them therapy as soon as you see it as well, is because inpatient facilities generally don't keep people there long term. So if they're not resolved, if the issues haven't resolved, then they can't necessarily stay there for long periods of time. So you want to have that support inside facilities and outside of facilities for people. Um,
Most of the time, I don't know what it's like in your area, but I know around here, it's like it's hard to even get into a facility.
Exactly. And that's the part that we're still trying to figure out in our profession is how do you help people who do need that? Even when you think about autism, for example, we ran a autism a group for parents who have older children with autism. Because think about it, in the schools, they help you with little children with autism. But as they start to grow and they become teenagers or they become men and women, who helps them? And it's generally it's not much resources. So, like you said, I think that's one of our biggest concerns now that hopefully we can tackle in these next years is how do we provide enough services for people? But anytime if someone says they want to harm themselves or someone else, then you definitely want to see if you can take them yourself to the hospital. If they have a therapist, then of course you want to call the therapist. Also, worst case scenario, you'd have to call the police. Now, there are like I had to do that one time. And I was actually on a computer with someone, and there are some places where they have the police officers trained or they have special units, mental health units. And
Yeah.
so I do encourage people, if you do have someone in your family who has mental health concerns, to see what resources are around so that you will know ahead of time and just be proactive in terms of that. Because some places have that, some places don't. Like I said, some places
Not
have
enough of them have it from
exact.
what I'm learning.
Oh, not at all. Not at all. And we actually, at our university, we actually have students who are doing practicums and internships with the police officers so that we can start to do more training there. But like you said, that's just one
Right.
small section of the state. So, yeah, I would definitely encourage people who have people in their family or their lives who have these diagnoses to definitely look at the resources around them and see how to access them quickly, because sometimes you have to access them really quickly.
Mm-hmm.
Yeah.
So I know we didn't talk about talking about this, but if how do you approach someone with, a loved one in your family or out of your family, it doesn't matter, just, someone you care about who seems to display these types of behavior around depression or anxiety and stuff, and they just don't want to admit that they have that problem or that they have that. I don't. What is the right terminology or language to use around? Is it a concern, an issue, a problem? What's the best word to use?
Yeah, and that's a little tougher because it's kind of like you have to decide that you do need assistance or that it's impacting you. Because even if they say, you tell them, yeah, and they agree with you, if they still don't go get any assistance, it doesn't really, make as much difference. But generally, if you come from, I always just tell people to come from a place of love. I notice you're just not yourself. And I noticed that, this is happening and this is happening. And I'm just wondering if there's anything that you need. Because you just seem, are you okay? You just seem a little different. And they're like, well, no, I'm fine and stuff. Okay. And you might give them a few examples of how, and just kind of say, I'm here for you. Or if you need any other assistance outside of me or outside of here, but I don't know how much. And like I told you, as you keep talking to other colleagues, they might have more of a different spin on it. Now, I know for parents, over the years, I started my career working with children and families, and I know parents would bring children. And there have been times when parents brought children and they didn't even know they were coming. They literally got in the car and they took them. They thought they were like going to the store or something, and they end up in my office like, "Who are you, lady?" And I
Must
kind of
be
laughed about it, but
trauma.
Right. Yeah, I kind of laugh about it now, but then I think about in those moments, we both were shocked. Like I'm shocked and they're shocked because I'm like, they didn't even know they were coming. So they're looking at me like, what? So then
Oh,
it's the
wow.
betrayal of it. And then it's like, you didn't even talk to them about it. So don't do that. I recommend nobody doing that. Like I said, unless it's something that's emergency and they need inpatient treatment, things like that. But really try to figure out. Also, I always believe as a behaviorist that, if people lead by example, so you saying, oh, I think you're depressed and anxious, most of the time people are looking at you too. So I always call it hypocritical. Like the people I train as therapists, I say, you can't tell people to be well and you're not well. You can't
Mhm.
tell them to self-care and you don't self-care. So that's the same thing. So you can say, oh, you have some depression, anxiety, but if you're walking around with depression, anxiety, they're probably not going to listen to you or not going to think. So I would say model the behavior. You go get help and go to therapy. Hey, you know what? I went to therapy and it was pretty good. Or I did this or talked to this or went to this group and, whatever it is. And so I would say model the behavior too, if possible.
And
Um,
sometimes, I think there's truth in sometimes your group of friends is your best therapy
mhm.
to get through things, and or you have a talk with the big guy upstairs, or whatever higher power you believe in, and if that calms you, it soothes you and makes you feel better, then that's okay. And I never have to leave my garage for that.
Yeah, and I actually appreciate you saying that, but this is the funny part. The one question that I asked every person who came to me, and 90% of the people could not answer this question. The question was, who are you? And many people could not tell me who they were. They can tell me who they used to be, who they want to be, but they couldn't tell me who they were now. So in order to do what you just said, you'd have to know that, oh, listening to music helps me to feel better. Going for a walk helps me to feel better. I know that's the second question that most people couldn't answer is, what do you do for fun?
Hmm.
People can't answer. I still ask that question every week now. Nobody, people can't. I used to do this. Okay, what do you do now? I watch TV, or I might play. Or if you're a parent, I play with the kids. Is that fun? No, I mean, not saying nothing wrong with the children, but you see what I mean? Is that what do you do for yourself for fun? Because you're probably entertaining them. So it's that piece of knowing who you are, so that those things could work. I have a good group of friends, and they even serve different purposes. If I need a good
Oh,
partner to come help
yep.
me do something, then I'm gonna call one. If I need a partner to pray with me, I'm gonna call another. If I need a partner that's going, just go and have a good laugh, I'm gonna call. You see, but you still
I'm
have
a firm believer in that one, and I taught my daughter the same thing. It's like you have different friends for different seasons, different purposes, and there's not one of them knows absolutely everything about me.
exactly. But the problem is, if you have some of that depression or anxiety, you're not interacting with people as much. You're not even interacting with yourself much. Or you're feeling like most people stay unwell because they either are too far in the past or too far in the future.
Mm.
I used to be this way. I'm always going to be this way, right? That's too far in either direction. But if you're present, okay, I don't want to get out of bed today. I'm okay with that. You feel better, even if you're in the bed all day. You see, so it's
Right.
so it's that who are you question, and if you can answer that and start to answer that, yeah, that's a good start. So yeah, you and I had a lady once ask me, well, how do you just by being a psychologist and there's God, and I said, well, it's interesting because you listen to the pastors or the whichever religion you have, who the leaders are, and you believe they're God sent. So why would not God not speak through other people?
Hmm.
And so it's not that we're gods or anything, but what the point is that he also brings, or she also, or however, whoever you believe in, brings other people around you to help you, just like your friends or your family and things like that. So there are professionals who do that work as well. And I believe many of us are called to do this work. We can I train a lot of supervisors, and we talk about, as a young age, we can talk about when people walk up and tell us things just, when we were little. And so I do think that that's a certain calling that we have to do it as well. So,
I would
uh,
100% agree with that because it's certainly not the money.
oh no.
And I think that's part of why there's not enough. So there's not enough resources out there is because it just is the pay scales. My daughter's been in this for Yeah, I mean, she got her master's in youth development and after criminology, criminal justice, and focused on the justice system, worked in foster care and the behavioral side and all of that. And it just is amazing how upside down some of the pay is for the things that should be important in this world versus the things that aren't as important as our, as the future of our population.
And that is so interesting that you say that, because I often find it fascinating that if you do not have your mental health, just like physical health, but if you don't have your mental health, you can't do anything. Like
Mhm.
you can't do anything. And so, like you said, we go to physical doctors and we give them money and give them resources, things like that. But or medical doctors, but the mental health providers, yeah. But some of that, luckily, we're trying to change and figure out how to do that for our profession and advocate for our profession as well. But like you said, yeah, our society it's an interesting thing.
It is. It's just backwards sometimes. So, all right. Well, I know we've spent a lot of time on this, but going back to what you were just commented on as far as the physical health versus the mental health, did you want to add anything more in regard
The
to
only
that?
thing I would say about that is, I do say to people, have you gotten a physical when they first come, especially if they have depression or anxiety, because there are other diagnoses that are physical diagnoses that could cause anxiety. So if you start to think about, especially of teenagers and women and things like that, I always talk about, because hormonal imbalances can cause that, of course.
Mhm.
Um, um, you think about anemia. I had some people before who, over the years, who had anemia that's caused some of those symptoms. So there are some physical Parkinson's has depression associated. Chronic pain can cause depression, anxiety. So physical health also could impact mental health. So sometimes if you fix your physical health, the mental health will get better as well. So that's something to think about. So usually everybody who comes, so I would suggest anybody listening, you go make sure you have a physical as well. And if they say everything is okay, then okay, it might be something that's mental health, kind of isolated and
Mhm.
outside of physical health. Also, medications can cause anxiety and depression. Of course, we already know some of the anxiety and depression medicine can do that, but also
Yeah,
inhalation.
every one that they prescribe causes symptoms from this. I'm like that. Same with blood pressure medicine. It's like, what the heck?
And I'm telling you, I had that personally happen to me with the blood pressure medicine. They gave me all three. I tried all three, and every one of them made my heart race so fast. And I was anxious and nervous, and I was like, okay, no. So I just have to walk now instead. So I can't take any of the medicine, and I just walk and figure out because that's a symptom of something else. So why is the blood
Yeah.
pressure high? But anyway, that's a whole nother conversation. But the point is, or inhalers or stimulant medications, things like that could cause those things too. So also look at the medication, and especially the combinations of medicines too.
Mhm.
So look at the side effects of medications and things like that. So that physical health could be impacting mental health too, where people just kind of see the mental health because the mental health is causing the issues, but it could be physical health things that you don't see, the
Yep.
thyroid issues, things like that.
Yep. You're checking all my boxes. So, okay, so let's kind of deep dive briefly into what is anxiety and how would somebody recognize that they have it? And then I think we've touched enough on the depression and understanding that, but how do you know if you have anxiety? I think most people would know, okay, yeah, I'm feeling kind of anxious about, I got to go give this speech or whatever. I had to come and do this podcast interview with you. And, you get a little anxious over it. But what actually is anxiety and the anxiety that leads to panic attacks? And
Yeah, generally, and like I said, that could be a whole nother show, but
yeah,
just to give you the brief version of it, this is the rudimental. So I don't want all my colleagues like, she didn't explain it, but basically, like you said, the one good point that you just made is that anxiety is something that we all will experience at some point in time based on what's happening in the environment. So getting married, having a kid, some of those same things could cause anxiety. And so there are certain things that are anxiety provoking that we want to occur. So having some form of anxiety is not unusual. The issue is most of the time when anxiety occurs, there's symptoms associated. Remember, so it's like sleep disturbance, it's racing heart, sweating, nervousness, and then there are different types of worry. There's different types of anxiety disorder. So there's generalized where it kind of happens in different settings and it happens no matter what you're doing. Then there's unspecified where it happens, but you don't really know why. I mean, it's all kinds of different ones that you could look at, but it just becomes a problem again when it impacts your functioning. So if you're anxious and then you get through it, so like if I was anxious before this podcast and then I started it and it reduced, or once it was over, it reduced, then we're fine. But if I'm 2 days later still thinking about, oh my gosh, the podcast, I should have said this, I should have said that, or if you're going on a trip and you have to, do everything, like this, then or you
All the
can't
what
bring
if scenarios running through your head.
yeah, and all this, and the worst case scenarios running through your head and things like that. But this is the interesting part, and this is the part where this diagnosis piece is so interesting because I have not met anyone who is anxious or depressed who didn't have something to be anxious or depressed about. So generally it's something that's current or it's something that happened in the past. Like I grew up in the hood, if you hadn't guessed. And so there are times where I hear noises outside. My husband did not. So he doesn't. I get up in the middle of the night and I hear noises. I'm going to go, am I anxious? You see what I mean?
Yeah.
But I can justify why it happened. Now, if I kept getting up every noise I heard, then that's impacting me. You see? So that's kind of how we have to look at it. Then there are some people though, which is interesting. There are some people who might be anxious all the time, but they function okay in their minds and in their life. So then do I diagnose them with a disorder? You see, so that continuum is it's relative for certain people, for certain diagnoses like those.
And it kind of goes back to what you were saying in the very beginning, that so much of this is in every disorder and all of it along the way is trauma induced by some trauma of some degree or another.
Mm-hmm. That's how I look at it as a behaviorist, but somebody else, another colleague, going back to that theoretical orientation, might look at it as something else, right? Like Freud might have looked at it as something that happened in childhood or something. You see what I mean? It could be different, how the origins of it all. But then, so usually what I do is spend time helping people. So if I say, okay, tell me what your main issues are, then what I'm going to do is help you. What do you want it to be like? And then I help you to get from where you're at to where you want to be. So yeah, I could go way in your past for a long time. I could do, but why? Because now we're here. So it's how I look at it. Like I said, somebody else might look at it differently. But generally with anxiety and depression, it's generally something. Usually it's something environmental. But there are going to be other people who might think it's something internal or they might, and then also, like I told you, it could be even we think about this birth with temperament and how people are. There are some people who they suggest might have some genetic pieces to it. It's just a lot to think about. So it's so individualized that it's hard to make really sweeping generalizations about these types of things,
Right.
which is why you talk to somebody.
That's interesting. Does it get passed on to someone else because it's actually in your DNA that way, or because of the way that of the environment you grew up in, or, is that the whole nature versus nurture thing?
Yeah. And it's interesting because I don't know if you saw this. It was this psychology has, of course, notoriously done some things incorrectly, but it's a movie called Three Identical Strangers. I don't know if you've seen it, but they had broken up these triplets basically at birth. But they found out, like in psychology research, when they do those twin studies where they saw if they were raised in different environments, well, actually, some of the parents didn't even know they had twins. They just broke them up and they didn't even know till later. But anyway, but it just depends. It depends. Some diagnoses we do think have genetic components, like attention deficit hyperactivity disorder, like bipolar disorder, like schizophrenia. Some of those have a strong genetic piece. The depressions and anxieties, we're not as sure. We don't usually think about it as much that way, but it depends. Like I told you, you'll probably talk to other colleagues who have definitive research that look at it that way. But we do know that there are some diagnoses that do have that genetic piece to it. So you are more concerned about, the offspring based on those diagnoses.
Mm-hmm.
Even with
But all
autism.
cycles can be broken in right? Or no?
Yeah, or you figure out, because like even when we think about schizophrenia, for example, usually it starts later on in life and it's usually triggered by something like maybe excessive stress, things like that. And so maybe if we do look at it from a more preventative perspective, attention deficit, I don't know. I think I used to work with those are my babies. I don't know. Sometimes you can figure out how to manage it, but I don't know if you can necessarily stop it.
Right. Yeah. And I don't want to sound like everybody can heal themselves or be healed from all of it. I know that it's a journey and it's either lighter or it's heavier. And it's not always about complete healing or getting over things. But
but I think people can treat things, especially if they're proactive. And that's the other thing I just would say before we end is that, if we can figure out, especially if your parents and things like that for your family, or if your family has a history of mental health concerns or your family environment is not the greatest and things like that, figuring out how could we be proactive in talking to our children or in looking at or healing these traumas or changing the environment so that the next generation won't have as many mental health concerns.
Well, that's certainly some of the mission of Glow for Hope. And number one, getting people talking about mental health like this and all the different things and to be better educated and not afraid to just even speak up but then also to, start giving the tools on the resilience and the mental toughness and the readiness, and the sooner we can get them, but then also help the parents or people that are going through it now is so important too. So,
exactly.
Well, thank you so much for joining us. It's been fun and very, very informative. And that will conclude this episode of Glow for Hope, Spark Conversation on Mental Health. And we'll see you next time. Until then, keep shining. Thank you for joining us on Glow for Hope. If today's conversation resonated with you, share it with someone who needs to hear it. Remember, your mental wellness matters, and you are never alone. For more resources and support, visit glowforhopenfp.org. That's glowforhopenfp.org. Stay connected, stay hopeful, and keep the conversation going. Until next time, keep shining.
This podcast does not and is not intended to provide medical advice. The information presented on this podcast should not be interpreted or construed in any way as a replacement or substitution for medical advice. It is important that you discuss your condition, treatment options, or any questions that you may have with your doctor or healthcare provider.